Hey, my name is Carol Warshaw, and I'm the Director of the National Center on Domestic Violence, Trauma, and Mental Health. Today's webinar is on responding to mental health crisis, the what and whys of self-injury, and it's part of NCDVTMH's series on trauma-informed responses to emotional distress and crisis. This presentation will explore what we mean when we refer to self-injury and why people self-injure. It will also speak to the role of trauma and how we can move beyond common misconceptions about self-injury to better understand and support people who access our services. Our trainers today will be Sera Davidow and Kathy Cave. Sera has been the director of the Western Mass Recovery Learning Community since its inception in 2007. She's also part of the statewide Certified Peer Specialist Training Team, a filmmaker, and a regular blogger for MAD in America, as well as a mother of two and wife of one. Sera also identifies as a survivor of trauma, including trauma experienced both within and outside of the mental health system. Sera speaks on a wide range of topics, including, but not limited to, trauma, self-injury, language, starting a peer respite, and developing peer roles. Kathy Cave, our other presenter, is the Senior Training Consultant for the National Center on Domestic Violence, Trauma, and Mental Health. Before we get started, I'll go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on the Using this Webinar System tab on the upper left-hand side of your screen. Please be aware that your screen might look a little different depending on whether you're using a Mac or a PC. On the right-hand side of the screen, there are multiple boxes. The second from the top is the chat feature. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in contact with the trainers or myself if you have questions regarding the training content. You may contact Angelica Medina, also with the center, if you have questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You'll see a lot of options. But for this session, you'll want to select all participants if you would like to respond to a question from the trainer or to contact me anytime during the session. You should click on Angelica Medina to privately contact her if you're in need of troubleshooting help with the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on all participants, type in where you're calling from, and then press enter. Perfect. Thank you all very much. So while folks can get a lot out of the chat feature, there are times when it moves really quickly and can feel distracting. If this is true for you, you can feel free to minimize the chat box by clicking the arrow next to where it says chat. You can always open it up again with the same arrow if you choose. We'll also be providing live captioning during this webinar. Below the chat box, there's a media viewer box. This will contain the captions. If you don't want to see the captions, click on the down-facing arrow next to the word media viewer, the same way you might if you wanted to hide the chat box. At the end of the webinar, you'll be taken to a very brief evaluation. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to internet connection, so feel free to call in if that's a problem for you. If you're experiencing technical difficulties and are unable to contact Angelica, you may call WebEx Tech Support to resolve any issues. That phone number, which we'll also post in the chat box, is 1-866-229-3239. Again, thank you for joining us today. I'll now turn the training over to Kathy.
Okay, welcome everyone. So thank you for joining us today. And again, I'm Kathy Cave, and I'm sharing the presenting duties today with Sera Davidow. And I wanted to start us off by talking about an integrated framework, which is the framework that the National Center on Domestic Violence, Trauma, and Mental Health has used and created to get us thinking about all of the pieces that are important in the services that we provide. So recognizing that many of you work in domestic violence advocacy, and I noticed from the chat box we have folks that are doing some other kinds of work, but human service-related work, and I noticed there's some folks from high school. So just thinking about all of the ways that we work together and connect together and try to provide support and advocacy, it's thinking about that as much as we really do need to understand the impact of violence, domestic violence and sexual violence on people and kind of what those responses are about and understanding the impact of violence and the way that we need to offer services. We also need to think about that a trauma-informed approach is one piece of the conversation. And when we're thinking about what does it mean to be trauma-informed, we also need to think about that it means holding a human rights and social justice context in all of the work that we do, understanding what the impact of trauma is and the many ways that people are experiencing trauma, the different sources of trauma, and what it means to really have a place in the world that identifies survivors and identifies people who've been harmed as whole human beings with a whole life. So it's what is it that we have to think about then in our services to say that, you know, justice matters and that we want to really think about that and consider that in all the work that we do. And in addition, we want to make sure that we're always holding a human right, in addition to our human rights and social justice context and trauma-informed approach and understanding the impact of violence, that the context of culture and community always matters. So there's this historical lens that we need to bring. There's a cultural lens, and there's our current community context. So what does that mean for all of us in the work that we do all of the time? And part of what helps guide what we do is thinking about a survivor-defined approach, which means that whatever we're doing for services is really driven by what the person or group or family is saying, this is what would be helpful, and then we act from that place. And considering both physical and emotional safety in the spaces that we create and the work that we do, honoring hope and resilience, and really working towards maintaining relationship and connection as a way to provide support and advocacy. So this certainly, the framework is something that we talk about a lot. We like to use it to open up our conversations, but also as a way of signaling that this is something that we're striving for in all the ways that we work and all the places that we work. As Carol mentioned, this webinar is part of a series on mental health considerations and concerns in domestic violence and sexual assault advocacy and thinking about what's helpful when someone is in crisis. In our previous webinars, what we've talked about is a set of tools. So we wanted to share this set of tools as part of this conversation today. So the tools include organizational policies and practices, and that everyone knows what they are and can act in a way that meets folks in distress with care and compassion and concern, but the policies also back that up and that people know what's expected. We talk about the tools of mind-body practices because we know that when experiencing crisis or preventing crisis, or to self-soothe and to honor what our body, minds, and spirits all need in order to feel connected and whole, it's thinking about what are some things we can do in the moment, offer each other in the moment, in terms of practices that people are able to access because they feel right. They feel like it's something that people can choose rather than something that's done to someone or that people are forced to do. So mind-body practices offer an opportunity to increase choice, to increase connection, and to offer opportunities for healing in ways that folks can find acceptable, find comforting, find helpful and useful. We also talk in terms of our tools about paying attention to physical and sensory environments, and that often the environments where we work and the environments where we offer services can provide, just by the nature of what people walk into, what the space can accommodate, people can access, again, and have choice for things that are self-soothing, self-healing, self-motivating, and that they're easy to access. So that in my environment, if I'm using services, I can see things that I can readily reach for and adapt to my own needs in the moment. And we also talked about having tools that center in asking people what helps. So if someone is in distress and in that very moment, asking folks then and there, what would be helpful right now? And at times when someone seems that they're in crisis or can't tell us, then it's also finding times when, even in those moments, trying to ask what would be helpful when people can't tell us what they need. Reaching for information that we know works, we know it's helpful because we asked on the previous occasion, we remembered, we listened, and we held on to what people said would be helpful for themselves. So part of what we're going to talk about today is really thinking about self-injury and understanding what self-injury is, how we understand and kind of navigate situations when it comes up so that we can recognize, each of us can recognize our own fears, our own discomfort, our own sense of worry. And, often that worry, concerns liability. Often that worry concerns the desire to be helpful but not knowing what would be helpful. So really thinking about when self-injury is common in our work environments, and it's something that many of us are uncomfortable with, even though it is something that is often present. We thought this would be a good topic to consider. Again, our goal is always around how do we stay connected and how do we maintain our compassion and empathy for folks. And when we were talking about in previous discussions and trainings and with questions that have come in on previous webinars in the mental health series, that often self-injury is one of the places that even when we start out from this place of compassion, our worry and our own sense of overwhelm can get in the way of maintaining that connection. So the goal today is to talk about what self-injury is and to really think about ways that we can maintain connection. So we thought it would also be helpful to start with just a reminder of when we've talked about trauma within this webinar series, this is really what we're talking about. So there's both the individual experience of trauma and this collective and historical experience of trauma, and that many of these different sources can be impacting one individual, and that one of the ways that people deal with stress and horror and the sense of being overwhelmed beyond one capacity to cope is self-injury. And we're going to talk more in our time together about what does that mean, what does it look like, why do people do that, and how we can be helpful and supportive. So keeping in mind this framework for what trauma means for us, we're going to go ahead, again, think about, here's many, many sources of trauma, and to think about that, again, we often understand in our work one source of trauma or one way that we think about someone's experience because it's what we're expecting. So if I work in domestic violence advocacy, I may not be expecting that there are other sources of trauma impacting the same person or the same family that's in front of me right now. So what we would like folks to do is really keep in mind that we don't always know everyone's experience. We don't always know history. We don't always know all of the facts in the present. And often with self-injury, because there's so much concern around judgment, folks may not be willing or open or feel like they can tell us what's happening because of fear of that judgment. So as laying this as a framework for today, I would also like to just encourage folks that when we're not sure what will help, to ask. And if people are able to trust us in the moment, they'll tell us. If they're able to trust us with some of the pieces, they'll tell us. If they're not ready to trust us yet, but we stay committed and connected and compassionate, then people will tell us. So I would invite everyone first to center yourself and really think about, as we begin this conversation, and I turn the program over to Sera in just a moment, to really think about what supports do you need, and can you, in this moment, reflect on what are your own views or your values or your concerns about self-injury. So if I invite folks to, all the participants, to please go ahead and use the chat box. Let us know as we're proceeding if you have some thoughts about what your own views are about self-injury. Are there ways that we can add to the conversation or questions you'd like us to consider as we're moving forward through the next hour or so together, to really think about self-injury and, what are your own beliefs and values, what do you know would be helpful, what do you think would be helpful, and any ideas that you have along the way. Okay. So with that, I'm going to turn the program over to Sera.
Hi, so thank you, Kathy. And, I come from a community and a kind of work that really focuses on starting with story and sharing pieces of ourselves in that way. So I'm actually going to share a piece of my story that's relevant to self-injury before I go on into other information. And when I share my story, I often share in these snapshots to reflect some of my early experiences without getting into too many details or taking too much time. So I'm going to start with these snapshots. And the first snapshot that I usually start with is of me clinging to my father's leg as I'm asking him not to leave because he's coming and he's gone and he's coming and he's gone, and now he's about to leave for the last time, and I'm about 2. And then I have this other snapshot of me with a neighborhood boy that my family had thought it was safe to leave me with and ended up not being, and I'm about 4. And I have this really vivid snapshot of me standing at the front of my childhood home with my hand against this cold pane of glass, and I'm terrified because I'm watching my mother drive away, and my infant brother is crying in the next room, and I'm all alone, and I'm about 5. And then I fast forward through all these other snapshots that I could share with you to the point of being 15, and shockingly, I'm not doing so well at that point, and I've started to self-injure, primarily to cut and burn myself, and I'm really not doing so well in school. And at that point, one of the things that really impacted the direction I was going to go in my life was privilege. I had the privilege of growing up in a family that had money, and so instead of entering into the mental health system or the foster care system at that point, what ended up happening is my mother called on an educational consultant to look into what could be done about me and maybe get me to boarding school or something. And what ended up happening was they introduced me to the idea of early college. And so 11 days after I turned 16, I found myself in an early college in Western Massachusetts. And I was so happy to be out of my home where I'd been experiencing a lot of negative things, but I was also terrified because I was just 16 and I was out of my home. And what ended up happening was that I did okay for a while, and then I wasn't doing okay. And I was, at that point, injuring more in all sorts of different ways. I was involving myself in restricting food, over-exercising, using drugs and alcohol, cutting, burning, etc. And I was less and less able to go to class and focus on doing anything positive for myself. And I managed to get transferred again to another school in central Massachusetts where I met my first therapist. And that first therapist didn't really ask me any questions about what had happened to me in the past. Instead, they diagnosed me. So that's when I got my first diagnosis. They told me I had major depression, a chemical imbalance, that I needed psychiatric drugs, and I would likely need them for the rest of my life to correct for that chemical imbalance. And in that moment, I was really happy. I was happy to have an answer. I figured that that was going to help me. And the only problem was that I continued to get worse. And I went through the same cycle of no longer being able to go to school. And in fact, I was in an apartment, and I ended up not really being able to leave one room in my apartment, and really all I was doing was just barely surviving. And I ended up getting shockingly kicked out of school, and what happened at that point was that I ran to Florida because I knew someone down there, and I met my second therapist at that point. And that second therapist asked me all sorts of questions. They asked me how often I was drinking, who I was having sex with, all these different questions of what I was doing with my life, and also about my self-injury. And that's actually the first time that I actually ever shared with anyone that I was self-injuring. And the result of that was that she said, "You are bulimic, major depression, generalized anxiety disorder, and borderline personality disorder." And that was the first time that I stopped being so sure that I was getting what I was looking for from the mental health system. But they, at that point, really decided what they needed to do with me. And when I self-injured, still really mainly focused on cutting and burning myself, what they decided they needed to do with me based on my diagnosis was that they needed to hospitalize me against my will. And so that led me to my first hospitalization against my will, where nobody asked me why I was hurting myself. What they did was they took away my means to be able to hurt myself, and I think they felt better for having done that. They also took away other things that were really important to me. At that time, I was going through this big ritual of putting on lots of makeup as if it were a mask to protect me from the world, and they wouldn't let me do that. They said maybe I would be able to hurt myself with the little tiny glass bottles, and the only way they'd let me do that was to have a large man stand alone with me, watching me in the bathroom while I did it, and I couldn't bring myself to do that. So I lost all these things that I was using to sort of feel okay in the world, and not once did anyone ask me why. And I could have answered them, maybe not as clearly as I can answer you now, but I could have told them that there are times when I feel so detached from my body that I'm practically floating above it and looking down on myself, and that when I self-injure, it helps ground me. Or that in this world where so many things feel out of my control and there's all this emotional pain that I have no control over, that the physical pain is something that I do have control over, and that's really, really meaningful and helps release some of that emotional pain. But ultimately, nobody asked, and then at the end of that hospital stay, a doctor said to me that I needed to stop doing this self-injury stuff because it was just to get attention. So I'm going to stop my story at that point, but I think what I want to leave you with as far as that goes is to think about the fact that ultimately what that did for me was make me realize that I couldn't go to the mental health system for help, at least at that point and in that place, that they didn't have anything that was making me feel better, that if I told them what was really going on for me, I was going to end up feeling punished by that. And so think about that as we go through the rest of the information that we have. Think about all the missed opportunities that there were, the opportunities to listen or ask me questions that never really got asked. And, you know, what I can tell you, and that we'll go over more in the slides as we move forward, is that ultimately those are not the people that helped me. The people who helped me are the people that dispensed with the labels and instead traded that out for listening, or the people who sat with me instead of trying to diagnose me, and the people who didn't make assumptions about what needed to happen next. Okay, so with that, I'm going to get into more of the content of our slides today. And the first, and you know, you've heard some of this in my story already, but the first point I just want to get at is what even qualifies as self-injury. And this basic definition that we have here for you is that self-injury includes any intentional act to harm one's body as a way of coping with emotional pain or stress. And a couple of things I'll just say here. You know, I know the title of this webinar is about mental health crisis, but actually for a lot of us who self-injure, self-injury doesn't necessarily represent mental health crisis. It doesn't represent a positive thing, but it actually in some ways represents our trying to avoid mental health crisis, the ways we've learned to be in this world without landing in crisis, and that this intentional piece of this definition is really very, very important. I recently went to a training on self-injury by a clinician who had no history of self-injury himself, and one of the things he listed on his examples of self-harm was withdrawing without permission from your psychiatric drugs. And that was really interesting for me because I think that's a very personal choice, and really what I think that reflected was his preference as a clinician that someone not do that without his say or without a doctor's say, rather than, is this really about someone's effort to intentionally harm themselves, or are they actually doing something that they think might be good for them? So I think there's a lot to unpack there, and hopefully we'll unpack it as we move forward. So here are some examples of what qualifies as self-injury. They include things like cutting, burning, hair pulling, pinching or scratching your skin, hitting, someone hitting themselves. It's certainly by no means a comprehensive list, but those are some of the most common things that people think of. And then there's this other list that are what I think of as more the socially acceptable ways that people sometimes self-harm themselves. So tattooing or body modifications, things like overeating or overexercising or overworking, use of alcohol or drugs. And I just want to highlight the intent here again, because tattooing, certainly not everyone who is tattooing is taking part in some form of self-injury. I mean, I guess in the most technical sense of tissue damage they are, but there are also people who have learned that they get in trouble if they cut themselves, but they don't get in trouble if they go get a tattoo. But the intent is really the same. And similar with alcohol or drugs. Lots of people have wine or have drinks, and it's not about self-injuring. I can tell you that when I was sharing my story and I mentioned I was using alcohol or drugs as a way of self-injuring, it was a time in my life when I was intentionally using the alcohol and drugs, and not even because they felt good, but because I was trying to punish or hurt myself or find ways to cope with where things were at in my world. And so, some of this gets into a lot of nuance, but it's always going to come back to needing to actually not make assumptions and talk to someone about why they're doing what they're doing, what it means for them. So to get more at this idea of socially acceptable self-injury versus non-socially acceptable self-injury, it's pretty important because in reality, most of us have or do engage in some sort of self-injury. And I'm using this picture of the owls because I like the owls, but also it's meant to demonstrate a point that what we think of as self-injury, there are similarities between all sorts of qualities of self-injury, but also they can be really, really different. And so I looked up on some sort of owl page, I think it was called Owl Pages, website this morning, and there were over 200 different kinds of owls. And in fact, there's as many reasons why people self-injure and what that looks like, and there's just no way to boil it down into one definition or explanation that you can apply to everybody. And as far as the differences between socially acceptable self-injury and non-socially acceptable self-injury, they really all can fit into that self-injury definition that we talked about. And they all have the potential to cause injury, but often actually the risk is greater with socially acceptable self-injury. And what do I mean when I say that? Well, I know for myself that I have caused more harm to my body when I have eaten or used alcohol and things like that to injure myself than, frankly, I ever have when I've cut or burned myself. And that honestly the risk of serious injury with things like cutting or burning is usually quite low. And that ultimately, and this is really important, particularly in your own examination of your own reactions to when someone is self-injuring, the biggest difference between non-socially acceptable self-injury and what is more considered acceptable self-injury is that the non-socially acceptable self-injury makes other people uncomfortable. So think about, I think, it's really important to just keep asking yourself when you think that you need to react in a particular way to somebody who is hurting themselves, think about whether or not that's coming from your own discomfort or from what you've actually learned may be helpful to somebody else. So this quote from Ruta Mazelis Trauma is the common link, the common ground for most people who struggle with self-injury is just meant to bring us back to this idea of trauma. Hopefully you heard from my snapshots, even though I didn't get into a lot of detail, that I've experienced a lot of trauma in my life, childhood, sexual, physical, and verbal abuse that also has continued in some ways into my adult years, and that a huge part of what I was trying to do, what I have been trying to do with self-injury is to manage what that has left me with in this world and to manage some of the pain and experiences that I've been through. And that, in fact, when people have diagnosed that at times for me, what that has felt like for me has been excusing the people who hurt me. And I can't say that every trauma survivor feels that way, but it's really important to me that when people hear my story, that they not twist it into something to do with a psychiatric diagnosis or anything like that, because it makes it feel like the people who hurt me in this world get a pass and that really the problem was something going on in my head that was always there. So why people self-injure? I think you heard some of that in my story, but there's any number of reasons. It includes that sort of needing to ground that I talked about. For some people, it's about numbness or emotional release. You heard in my story that some of it was about the idea that the pain is controllable when nothing else is. That can be huge, especially when you're thinking about trauma-informed environments and how important it is that people have a sense of control, because so much of trauma is about a loss of control. So that controllability of that pain that you caused yourself is really big for a lot of people. And it can be a way to communicate suffering to others, which is very different than saying, oh, you're just doing that for attention. It's okay to want attention. It's okay to need to look for other ways to communicate what you need from people, but that sort of, oh, you're just doing it for attention thing is pretty dismissive, or at least it sounds that way to me. Reducing anxiety or stress, reducing an urge to kill oneself, and distracting from other distressing experiences. And on that last point, that can be distracting from a flashback, from trauma. It can be for some people who hear really distressing voices. Sometimes they're using that as a way to distract from hearing a distressing voice. And sometimes these things work only for a period of time. Sometimes they work really well, and sometimes they stop working. So it's always going to be important to ask people why. And I see that there's at least a question or two popping up in the chat box, but I'm going to try and get through some more of this before we go to questions, but we are going to make a lot of space for questions at the end. I'm going to go through some myths here that are really common. I'm sure some of them will sound pretty familiar to you. One of them is that self-injury is mostly used by young white girls. Now, I may not be the best person to dispel this myth, because when I started this, I was a young white girl, but the truth is that self-injury is something that shows up across all ages, races, ethnicities, cultures, genders. It's just, I think that because of TV portrayals more than anything else, it's been pegged on young white adolescents, but it's really, that's just not an accurate perception. That self-injury is most commonly the result of an issue related to a psychiatric diagnosis. It's tricky, this issue of psychiatric diagnosis, but I think that you will find that there are many, many, many more, hundreds of thousands of people than just me who say that actually what I experienced was trauma, and that people have tried to layer over that trauma something about psychiatry and the psychiatric diagnosis. And that's not to say that there's no value in that way of looking at things. There's lots of people who find value in that, but it's not a great place to start with self-injury. So there is this sense often that people are using self-injury to try and manipulate somebody else. And again, that's a really negative way of looking at things. like I said earlier, it can be a way of trying to communicate pain, but that's very different than trying to control someone else. You know, I already said that creating trauma-informed environments is so key to make sure that people feel like they have control for themselves, and generally this is much more about control for myself, ways to be in the world for myself, than it is trying to impact somebody else. Sorry, here we go. So hospitalization. It has been really common. Fortunately, it's growing less common to think that if someone is self-harming, that hospitalization is going to be helpful. Now, why is it not a good idea? Well, if someone is telling you that's what they need, I'm not saying not to listen to them, but I will say that hospitalization for somebody who does not want that, that's a huge loss of control. So to go back to my example, when they hospitalized me against my will because I was self-injuring, it was a huge loss for me, a huge loss of control, a huge loss of the rituals that were helping me to feel safe in my body and in the world. And nobody actually in the hospital was particularly well trained to even talk with me about that or ask me why I was doing what I was doing. And that doesn't mean that there aren't professionals out there who aren't capable of that or haven't been given this information and aren't better, but it's just a really unnecessary step to rip someone out of their world and put them in such a controlled environment unless they are the ones saying that that would actually be really helpful, or, you know, the self-injury, which is really very rare that there's some actual medical emergency that's been caused by the self-injury. And this is getting at the same idea, this last myth I'm going to talk about, this idea that your goal should be to convince someone they need to stop self-injuring and or to control them, take away things like knives, etc., until they do. Now, it's an understandable human impulse to want someone to stop, especially when we're looking at that socially not acceptable kind of self-injury. It can be scary. It can be upsetting, especially if it's someone that you care about in your family or a child, to see someone intentionally hurting themselves in such a clear way. But again, that gets back at what I said, and actually also what Kathy said at the beginning. It's so important for us to examine why we are reacting in the way that we are reacting so that we don't just automatically put that on somebody else. Because I can tell you that when people have approached me with the assumption that I need or want to stop self-injuring, they have lost me. At that moment, they have lost me. It's when they ask me questions like, so how is that working for you? Is that something that you want to stop? You know, what would that look like for you if you did want to stop? Those are the questions that make me feel like someone's interested in me rather than just controlling me. And those are the questions that lead me to want to even have a conversation with somebody. And I don't mean to use me as the representative for all people who have ever self-injured, but I know that the experience that I'm offering you from my own story is echoed from so many people, and that it's never going to hurt someone to ask them those sorts of questions, and it really can hurt them to skip that step. So I'm going to go through just some tips on how to help and how not to help. I'm going to start with how not to help. And some of these you're going to hear, they're echoing. The lists are echoing one another. And part of the reason that we do that is because some of these things, although in some ways they might seem obvious or repetitive, they really bear repeating because they run so counter to what we have been taught in this world about how to help people. And there's a quote, you know, that flies around that I don't know if you've heard. I've heard it sometimes attributed to Pat Deegan or to others, but it's basically this idea that help doesn't help unless it's actually helping. You know, so And I think I'm not, getting it quite exactly as it's written, but it's that idea that you can call something help, but if it's not actually helping, then you can't really legitimately call it help. So the first one here is to not make what's happening about you. And again, that can be really hard, and it doesn't mean that you have to leave yourself out of the equation forever. That's why it says in parentheses on this slide, at least not to start. It's okay at some point to say, this is really hard for me, or I don't know how to help, or when you do that, here's how I feel. But if you start from a place of, I can't handle this, or you need to stop to make me feel better, very often you're going to end up losing somebody in that conversation that you really, I think, are trying to step into helping. Again, this idea of psychiatric labels or the idea that self-injury is just a symptom. It is true that self-injury is generally not the full picture. Usually it is a response to something else, but it's a really meaningful response. The effort to try and make someone feel guilty, that comes up an awful lot with not just self-injury, but also when people are talking about suicide, this sort of response of, it's terrible that you're doing this, or what will your children do, or think of all the people that you'll hurt. It's not the most helpful response. Unless someone tells you, hey, when this is going on for me, remind me how much my kids care or how much they need me. Unless they've told you that, sometimes that guilt and shame that is already often so present for people who've experienced trauma, growing that is not helpful. I know that some people work in environments that suggest that calling 911 or a clinician is the right response. Sometimes they suggest, particularly in the world that I work, a lot of people are working in peer roles. They'll say, someone in a peer role does not have the training to talk with someone who's talking about self-injury or suicide or anything so serious, and you need to bring in a clinician right away. And unfortunately, what that does is it creates this sense not only for the person in that role, but also for the person who's seeking support, that they can't be trusted, that they're this dangerous, fragile thing that someone else has to come in and deal with somehow, when in fact, really, the best training that you can have very often is the training of how to be human with one another and how to listen, and those kinds of connections that we can build with each other when we don't jump to panic buttons are so key in people even being willing to talk about what they need. I don't know if any of you are familiar with the open dialogue system. There's an open dialogue system that is a clinical system out of northern Finland, and there's a number of things about how they approach psychiatric crisis and emotional distress that are very different from how we do in the United States. But altogether, one of the things that it has led up to is that people trust that system. People trust that system because they get responded to right away, because there's not an assumption of diagnosis or a need to lock someone away. And so when someone's in distress, they reach out for help right away, rather than in this culture where people tend to hide what's going on for them for a really long time until it really gets really bad. And that's not what I think we want, but sometimes it is the environment that we foster when we jump to calling someone else in. Don't make assumptions about why. I've given you some potential reasons why, but some, all, or none of them may apply to different people. There's so much that's important about making meaning in why we do things, and sometimes there have been points in my life where I've needed some support to really think about why. Ultimately, I had the answers in me, but it required someone not making assumptions and actually just sitting with me and asking me questions that helped me get to why something was happening. I'm actually going to share just another brief little story that's a little bit outside of the box of self-injury that gets at that idea. In 2010, I had 2 miscarriages, and it was an extremely traumatic time in my life. I didn't know why that was happening. It was really, really upsetting for me. And then in 2011, I became pregnant again. And what happened for me was that I was kind of existing in this extreme state almost all the time, even to the point where when I would feel my baby kick when my pregnancy was a little further along, I immediately thought she disappeared after that. So I was running home from work, and I had rented a baby heart monitor, and I was just almost always in this panic. And I thought that would all be done when I had her. And then I had her, and it wasn't done. And I started getting these visions that were telling me to hurt her. And that was terrifying, and it was not something I was going to tell anybody ever, that I was having these visions telling me to hurt my baby. That's not something that people usually respond to well. That is something that usually leads to the panic button, so I kept it to myself for a long time until I had an opportunity to sit in what was called a Hearing Voices group. And if you're interested in learning more about that, there's lots of resources online, but it comes out of the Hearing Voices movement. And although it was a vision rather than a voice, in this group, all of a sudden I had a chance to think about and listen to other people's experiences and try and figure out having the space about why was this happening? Why was I having these visions? And why were they particularly strong when I was in this particular part of my building at work, where I work most of the time? And what I ended up figuring out was that I had blamed my body for those miscarriages. I had thought of myself in some way as having killed these other two babies, and I was still carrying that around. And that, in fact, the place in my work building where those feelings and those visions were the strongest were where I had experienced the feelings of the first miscarriage starting to happen. And when I got to the point of being able to make that meaning, then I could talk to people, and it's when it stopped, not immediately, but it started to fade away, and it started to mean something very different to me once I could make sense of it. So not making assumptions and really talking to people about why things are happening is huge. And again, this idea of not trying to take control or take away items used for self-injuring. It's important to remember that people have lots of different ways of self-injuring, and I can say for myself, and I've heard this story many times from others, when other people have, without any consultation with the person who's self-harming, simply tried to take away the means for self-injury, often they've become even more desperate to look for a way to harm themselves. And even in a hospital, honestly, people find ways to harm themselves, very creative when they feel, really pressed to need to find something to injure themselves with. And unfortunately, that can also lead to the sort of power struggle that leads people into things like restraints in hospitals, and that can cause more trauma, and it can become this cycle that people get caught up in. And here's a quote from Bhatia: taking away the person's protective mechanisms may not only increase the behavior and undermine the therapeutic relationship, but may actually be dangerous. And we've talked about some of this, but I also want to point out that earlier, one of the reasons that we mentioned for people sometimes self-injuring is an effort to reduce the thoughts of suicide, and that certainly has been true for me and for many other people. And I'm not sure if people have seen the research, but there's a growing body of research that the risk of suicide actually increases. It is actually at its highest point the week or so after someone has been released from a psychiatric hospitalization, particularly where force was involved. And I think there's many ways we can interpret that data, but one of them is that when you forcefully take away someone's ways of protecting themselves or feeling safe in the world, that sense of lack of safety can get really, really big. And so sometimes if that's what's helping someone not be suicidal, and the act of taking that away can actually make things much, much worse. So what is helpful? Well, number one is what my husband is really terrible at, which is listening without interruption or judgment. My husband is forever stuck in this must make it stop. If I don't make it stop, I'm failing at my job sort of mode. And, I have not found the right way to explain this to him to get him to shift out of that. But I think that's more his own stuff. But, again, the people who are often cited as most helpful by people who are self-injuring or going through most kinds of distress are the people who just listen without interruption or judgment. And the people who, again, ask about what it means. When you do that, what does it feel like? What is it doing for you? Why do you do that? Those sorts of questions. Again, asking someone if it's something they want to stop, because if it's not something they want to stop, then anything you do beyond that point may be regarded as force of some sort. Being willing to just sit even in silence. It's okay to not have answers. It's okay to even say you don't have answers and you're not sure what to do. But if you can also, in the not knowing, be willing to just sit with somebody, then that can be huge. And Kathy mentioned at the very start of this, people who aren't able to communicate what they need. Sometimes what it is not so much that they're not able, but that they're not able in the ways that we're expecting. So I've been with people who couldn't communicate out loud, but they could text, or they could write, or they could communicate in some other way with their bodies what was happening for them. And you're not going to get to that unless you're also willing to sit through some silence or just be with somebody or develop the sort of trust that comes from demonstrating that even if there's no immediate answer, that you're not just going to walk away. So being willing to explore poetry, books, films, blogs about self-injury or anything related to emotional distress can be great. Lots of people get handed resource lists. I've been handed many lists. I've been handed many stacks of paper or sent to many websites. But the act of doing that with somebody can be really powerful. Watching a film, talking about it can be really meaningful. There are films about self-injury or a number of related topics. One of them that comes to mind is one that Ruta Mazelis herself is in called Between the Lines. It doesn't have answers, but it just has stories and images that can really spark conversation. And similarly, beyond poetry, books, films, etc., the willingness to explore resources or strategies. So actually going somewhere with somebody rather than just saying, hey, I know there's this group over here, and I think they talk about that. Being willing to go with somebody somewhere can be the difference between them choosing to go or not. And there's this other piece, we're talking a lot about how not to bring in other people to the conversation unless it is wanted, but you might find yourself in a situation where bringing someone else in is necessary, whether it's because of somebody's age or you just feel like you can't sit with this on your own. That's okay as long as it's not your everyday go-to response. But if you're going to bring someone else in, the person that you're trying to support, the person who's self-injuring, should be as involved as much as possible in that process. And what does that mean? It might mean that they decide with you who gets brought in or how, or that they make the phone call rather than you, or whatever decisions that they can make, whatever decisions that can be in their hands. That's really important. And absolutely, without a doubt, it is key that you not do that behind their back. There's a long history, at least for those of us who've been in the psychiatric system, of people saying, hey, keep them busy over here while I go call this person over there. That's can be experienced as very traumatic and a real breach in trust. Some of the resources and strategies that it may be worth looking more into are here on this next slide. And, there's lots of them. We're not going to get into a ton of detail today, but I will just go through these somewhat quickly. One is called a replacement strategy. And you'll find that people really react differently to this idea. Some people think it's great. They love having, say, a rubber band on their wrist that they can snap sometimes that is not actually going to cause tissue damage, or really cold ice or other kinds of sensations can be effective depending on why somebody's self-injuring. And again, this gets back to that idea of why. If you don't know why someone's self-injuring, if you haven't supported them to explore that, it's going to be really hard to help them figure out what might be useful if they want to stop. You know, a replacement strategy of how else to cause pain or similar sensations is going to mean something very different if someone is trying to use self-injury as a way to communicate their pain versus if they're just trying to ground themselves. So again, asking why is key. Trauma, making meaning, I talked about. Harm reduction, that can just mean, you know, if you are going to cut yourself, can you cut yourself with something that's not going to cause infection? Or what do you do afterwards to prevent infection? Or, you know, for any kind of self-injury, looking at what are the potential risks. It can also mean if you're going to do something like this and one of the risks is that they're going to hospitalize you against your will, is there a way to do this that won't lead to that result? And I don't mean secrecy. There's a lot of secrecy in trauma, and so that's not usually language that I find to be particularly helpful. But I do think there are ways to have that conversation that just talk about the real-world risks of the choices you make and how to think through what to do about that. Therapeutic relationships, peer support, some of the things we just talked about, groups, books. You can, of course, find a lot of this kind of thing online. And what does this all look like in groups? Well, in group environments, and this is something that I've had to consider quite a bit because I am the director of the Western Mass Recovery Learning Community, and as a part of that community, we have something called a peer respite, where people can stay for up to 7 nights as an alternative to a psychiatric hospitalization. So it has come up. You know, what happens in a group environment when someone's self-injuring? Is the response different than if they're just in their own home or in a one-on-one kind of interaction, because multiple people who are experiencing emotional distress are there at the same time? And so part of what I would say is everything that we've already talked about still applies. You know, what self-injury looks like, what can be helpful still applies, but you do need to add in the consideration of how that intersects with the group's needs and goals. And so that means thinking through ahead of time, ideally, so that you don't find yourself in this situation, because this is fairly predictable in an environment where people are distressed that someone at some point is going to self-injure in that space. You know, how are you going to respond to that? And sometimes that might get dictated by a funder or somebody else, but for us, we got to dictate that. And so what we have said is self-injury is something that we ask not happen in the public spaces. So the community, the living room, the kitchen, but we are not going to ask someone to leave if they do it in their room. And we will respond in the same way that we've already talked about through this last hour, with questions and with being with someone and asking what that means for them and so on. And this is going to mean that this sort of training, this sort of conversation needs to happen for everybody who works in that group environment. Everybody's going to need to be aware of what the guidelines are for responding. Everyone's going to need to be aware of this need to sit with our own discomfort and to understand what are some of the helpful responses. So it needs to be some intentional conversation and training with an entire team. And it's also important to remember that if a policy requires a punitive or potentially negative response, that be shared up front, whether that be if you talk about killing yourself, we must call X person or we must ask you to leave or what have you. That should be shared up front and preferably shared with other resources where someone could talk about that without a negative consequence. So if that has to be the policy of where you work, then perhaps you're also sharing the number for a peer support line where it's not the policy. So they still have a place to talk about, and you're not perceived as saying, you can't talk about this because it's bad. You're simply saying, you can't talk about this here without these negative consequences happening because of whatever the reason is. But we understand there's still a value in talking about it, and so here are some resources for you. And so I kind of covered those last 2 bullet points together there. So I'm going to turn it back over to Kathy now to talk about young people and self-injury.
Thank you. Sarah, thanks so much for sharing all that information. And, you know, many of us are trauma survivors, and some of us have used self-injury as a way to cope with unbearable pain. Others have other ways, and some of those ways are socially acceptable, and some of those ways are not. And one of the challenges with children and youth and young adults even is that there's often, depending on the setting you're in, there's different understandings, there are different expectations around liability and accountability. And so we wanted to be clear to just acknowledge that that is true. Depending on the setting that you're in, there's policies and practices. But I think it's also helpful to revisit those policies and practices in, you know, with a lens towards this conversation around self-injury and really think through what does this mean for us here and now in whatever setting that you're in, and to think about that and talk about that in real ways. Because it's not that this doesn't happen, it's that it often happens in secret, and then folks are either unable to share it in different ways, and with, again, depending on, you know, as a helper, what your perspective is, wanting to, you know, stop or fix or shift it in some way. So while that's a natural response to want to stop someone, when children and youth are involved, we feel we have more either responsibility or accountability or liability, or maybe all three, around making things stop. And I think what our message is today is that what's helpful for children and youth doesn't change, in that the more transparent we can be, the more compassionate we can be, the more understanding we can be in terms of being a person who can hear and listen and be with as people are telling you, this is what I'm experiencing. So whether the person is 8 or 15 or, you know, older, it's can you hear when someone is telling you, because that moment is so important. And you may be the first person that is allowed in. So it's really thinking through, how will I respond if this young person tells me, and what's my responsibility? So the what's my responsibility part is also something that you need to know up front. So when we started this webinar series, one of our conversations was around policy and practice. So it really is important to know what the policies and practices are. So as staff, what's expected of each and every one of us. I think that managing, reflecting, owning our own feelings about powerlessness is also really important, in that, again, we want to make it stop. So if we come at someone, and I'm deliberately using that language around coming at someone because they have a way that they're self-harming and that's concerning, then one of the questions is, can I stop a moment? Can I just stop and take a breath and be with the person so that I can respond in the most caring way possible in this moment? And then as Sarah was saying earlier, if we do need to call someone else in, so if it's an organizational responsibility, you're a mandated reporter, there's rules and accountabilities around, you know, the way that you have to respond within your organization, then it really is important to be very transparent about that. And it's acknowledging that the person trusted you, they shared something with you. It's also not assuming that we understand or know what the underlying reasons are. So if someone is self-injuring, I don't want to be guessing at what's the cause of that. If I have an understanding, I may have some questions around how does that help? How does that work for you? And I'm wondering if there are other things that we can do. So there's lots of different kinds of conversations that you can have, no matter the age of the person. But I think the other piece that makes it challenging around with young children is what's the role and responsibility of the parent. So if I'm in a shelter and there's a young person and the parent is there, And, I have a responsibility to make sure that the parent knows what's happening. I want to be as clear as I can with the child when the child has shared that with me. And I want to be, it's not these are not 3-minute conversations. So it's like, oh, you told me this, we have to go tell your mother. It's really more of, thank you for sharing this with me. I know this is hard. And one of the things that we have to do is, when people share this kind of information, we want to make sure that everyone who needs to know knows. So let's go. Can we go now? Can we share that with your parent? And really thinking that through, having some understanding of the relationship between the child and parent and supporting the parent's role, but also being very, very clear about roles and responsibilities and knowing that this moment that someone has shared this, that a child has shared this, may be a magical moment and may not have shared this with anyone before. So what happens matters. So compassion matters. Non-judgment matters. Understanding matters. And being present in a way that says we have to share this information and I'm here with you while we do that is also really important. So I wanted to pause here a moment and to consider if there are questions or comments from the group. And Carol, did you want to say anything?
I'm pulling out the questions to a file so I can, what I wanted to say was to thank both of you for such a really thoughtful presentation. I was going to say that if anyone has questions, to please type them into the chat box. And in the meantime, I can ask the two of you some of the questions that came up before. Does that work?
Sure.
Is that what you were ready for, Kathy? For the question part? Okay.
Mm-hmm.
So the first question that came in was, when does self-injury require inpatient hospitalization? Why are superficial cuts not as urgent as other cuts?
I think that, I spoke to some of this when I was speaking earlier, but I don't know that I've ever needed a hospitalization. I've been hospitalized a couple of times as a result of what were not life-threatening examples of self-injury. They were never helpful. And, I'm, I think, 25 years past that with many years of self-injuring at different points in my life, and there was no point when it was useful. I think when it becomes necessary is either when someone says, I think this environment would be helpful to me, or when there is an actual life-threatening thing happening. And then usually what I've said to people is, it's no longer about self-injury or how did we get here. It's about that there is a medical emergency. I don't know that there's a black and white answer to that otherwise. Hospitalizations, there are people who have found them helpful, but it's a lot to lose, a lot of power to lose, a lot of potential for re-traumatization that happens in a hospital environment where you've been put against your will or locked in. And so, I'd be hard-pressed to answer that in any other way. I don't know if you have more to say, Kathy.
Thanks, Sarah. I think I agree. And one of the things that I would add is that, at different points in this series when we've talked about mental health crisis, one of the things that we've often talked about is that there are a range of survivors' views or a range of people's views about what they find helpful. And what most folks say they want that has been helpful is someone listened and someone was with me. So I think often about, there's a poem called The Invitation, and one of the lines in the poem is, can you sit with pain, mine or your own, without moving to hide it or fade it or fix it? And I think in our advocacy work, that's where we're partnering. We're hoping to be here and be present, and our intention is to be here and be present And I think in terms of self-injury, it's hospitalization is when someone says, this is what would be helpful to me, or that there's a medical emergency because as a result of harm, of self-harm, not necessarily that it's the self-harm. So it's not that, because I'm cutting myself that I need to be hospitalized. It's because something happened as a result of that. Now it's life-threatening. So it's the cutting in and of itself. It's not life-threatening. The burning in and of itself, not life-threatening.
Yeah, and I would just say, even when someone says hospitalization would be helpful, I do not see a value in arguing with them, but sometimes there is a value in saying, what about it would be helpful?
Mm-hmm.
Because sometimes at that point you discover that actually they don't necessarily want to be locked in a hospital for 7 days. What they really want is to be out of their current environment, or any number of other things you might discover about what people do find helpful, and that can open up a whole other conversation about really what's a long-term plan for what's going to be helpful when you're in this space.
Thank you.
Thanks. So the next question was, I think you answered, is it a way to escape and take away the pain? So do you want to respond to that, Sarah? I think you kind of addressed that already.
For some people, absolutely. It is a way of escaping or, taking away at least a certain type of pain. But I think it's important that it not be assumed that that's what it means for everybody. And, I've said this a number of times at this point, but I'll say it again here. Asking someone themselves what it means for them is really, really critical, because not only does it help you learn, but that act of asking that question may help someone who's actually self-injuring surface what it means for them, and that can be a really important part of their own process as well.
Thanks. I'm going to skip to some of the questions at the end about policy and then come back to some of the earlier questions. There were two near the end that were, one was I'd like to know what some of your thoughts are on combining policy and control to the person, combining policy and control to the person who's self-injuring in an inpatient hospital. This is the setting in which I work, and one of the first things we do is take away anything that we think the person may harm themselves with. And the other question related is, how else can policy be influenced along with helping to keep the person safe and heard? So it's the control and safety, kind of balancing all that, I think, that maybe people are wanting to hear more about.
Well, I think that hospital environments are, how to make a trauma-informed hospital that considers the voice of people hospitalized there is a big question. Actually, there's somebody that I know very well in England who's working on just that sort of project of how to make a contained unit where the real focus is being trauma-informed, and I'm curious to learn more about how he's doing that. But I think that, I'm looking at this question. I'm not 100% sure I fully understand exactly what's being sought here, but I do think that hospitals tend to skew so far in the direction of control that, just like, the rest of the conversation that we've had, they do harm, So I have heard, I think of one particular story of someone in a hospital who said how important listening to music was to them, just to get through their day, to manage their emotional distress, to feel like they are in the world, and yet the hospital took away the music because of the headphones that had those little wires attached to them. And it's the same justification I hear for things like cell phones being restricted. I was on Facebook posting a picture, I think within 20 minutes of my daughter being born, but when I was in a psychiatric hospital, there was no phone access whatsoever as far as my cell phone was concerned. These things get taken, these things that are so meaningful for us, and I think those are the sorts of policy places that you can make a real difference, that there can be conversations had with people who are hospitalized about how important these pieces are and how much harm is done by taking them versus what risk really is there for allowing them to be in the environment, or are there creative ways to create access without just fully taking them away. And, I work a lot with hospitals in this area, and one of the things I've seen is that the hospital 5 miles away from me says we absolutely cannot allow, containers that have not been fully sealed here, and we cannot allow anything with staples because they might be used for self-harm, and our regulations require it. And then the hospital 10 miles away says, oh, yeah, sure, containers of coffee from Dunkin' Donuts are fine, and newsletters with a single staple in them are fine, but we absolutely cannot allow for headphones here because our regulations require it. And each hospital becomes its own little bubble, and they all have those different restrictions based on probably something bad that happened 10 years ago. And it was a legitimate fear, but it's become this overarching policy that each hospital has, but it's different from one another, and they all regard it as something that cannot be changed. So perhaps the first step with a hospital is to realize that most of these things came from something like that, and they could be changed, and sitting down in a group with people who work there and have been hospitalized there to talk through some of that can be a really important part of the process.
Thanks, Sera. So really trying to figure out what actually is going to be most helpful rather than just responding out of fear of liability or from previous incidents, and trying to be creative about that with people. So some of the other questions, one was, is borderline personality caused by traumatic experiences? What does borderline personality disorder do to increase someone being involved with self-injury? And then another question is, when someone hears voices or sees visions, what can they do to help decrease these experiences?
Okay, so I might not be the best person to answer the questions about borderline personality disorder because personally, although I was diagnosed with that, I've disregarded it as a valid diagnosis. A lot of people in the movement that I travel in really don't feel great about that diagnosis, and but I think in the most technical of terms, yes, what ends up getting labeled as borderline personality disorder very often seems to stem from a number of traumatic experiences and the ways in which people come to deal with those traumatic experiences. And what was the second half of that question?
Actually, can I speak a little bit to the borderline piece?
Yeah.
Sure.
Yeah.
And I'm so appreciating your response, Sera, so thank you for that. I've worked in mental health systems, programs, statewide administration, and one of the things that I've felt over the last 20 years is actually a reframing of the notion of a borderline personality diagnosis, and that label was often applied to folks who were behaving in particular ways and having particular experiences related to trauma. And really thinking about that it's much more helpful to actually understand what people have experienced, to understand the ways folks have been impacted, and then the ways that as providers and supporters we can do what we do. And that, particularly in, again, over the last 20 years, I've seen the shift in even the way that clinicians are thinking about and talking about and working with our understanding of borderline personality, and really reframing that whole conversation to be much more about there's an impact to trauma when trust has been violated, when the violence we experience has been so devastating and disruptive that it's hard to stay connected and grounded as a human being. So it's understanding that when that is the impact of trauma, and again, thinking about trauma in all the ways that we've been talking about it, from this interpersonal violence piece, this historical and community perspective, that this happens and this is real, and much more helpful to think about what are the impacts of that and can we be helpful, what will be helpful. And othering people doesn't tend to be helpful. So how do we stay connected? How do we understand it? And are there things that we can do to be supportive?
And another way to think about that is when the ways that we develop to manage internal states of, feelings and being grounded and connected and how we feel about ourselves and other people in the world have been disrupted by trauma, then we often have to use external means of managing internal states. And so this is self-injury is one way that can happen. And understanding it in that context makes it gives you a very different perspective, and it gives you a different perspective on what's actually helpful to people. So, one of the things with the diagnosis of borderline personality disorder is it has become a kind of pejorative label, and the majority of people who have been given that diagnosis are survivors of childhood trauma. And so a lot of people, as Kathy, as you've been saying, have used more of a complex trauma lens as a way to understand the impact of trauma and actually what's helpful to people in those experiences, so that part of what would happen in some of the ways people would respond would end up actually be re-traumatizing or re-victimizing, and then that would just keep things, do the opposite of what we would ideally want to be doing when we're trying to be helpful to someone. So,
Carol, what was the second part of that question? There were two.
It was, what does borderline personality disorder do to increase someone being involved with self-injury? So that was sort of what I was trying to address. Yeah. Did you have more?
No, I thought there was another.
There was another question. Yes, I put two questions together because I wanted to make sure we got everything in, and there's one more after that. When someone hears voices or sees visions, what can they do to help decrease these experiences? And the last question that I'll come to is really about healing from trauma and not being re-victimizing. So I'll do that one after you respond to this.
So I think the first thing I would say is, again, here's a place where it's important to not assume that the goal has to be to decrease those experiences. In fact, there are more people in this world by many, many, many stretches who hear voices or see visions who never seek help or try to stop it than those who do, or at least that's what research is telling us, and that there are a number of people who actually see benefit in the voices and visions that they experience. And that benefit can come in a few different forms. For some people, there's, for instance, Jackie Dillon, who is a pretty prominent figure in the Hearing Voices movement. She says at this point she's done a lot of work, and the voices and visions that were negative have really dissipated, but the voices that she hears at this point are really positive, and that she appreciates them, and they keep her company, and that she would not want them to go, and it's just a different way of being in the world. And then there are also people who say, I used to be really afraid of this voice until I learned what it meant. And what I learned it meant is something like, when this voice comes up, it's warning me that I'm in a situation that is frightening, or it's warning me that I'm in a situation that might be dangerous, or things like that. So once people can give it something meaning, sometimes it becomes less of a problem. So sometimes the problem is just starting from that point of, we are aiming to decrease this experience rather than to understand and integrate this experience. That said, there are lots of people who do want it to just go away, and that's also valid. And I think then there are a number of ways in which that can be approached. Like I said, for me, what was most helpful was the act of making meaning of that experience. That is what really led for me for it to go away. It was almost like it was going to keep going. Like I've heard some people, I think Peter Bollamore, who's also another big figure in the Hearing Voices movement, he said, what happens to your child when they're saying, Mom, 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 and you ignore them? Do they go away or do they get louder? And of course, for most people who have kids who have experienced that call of parent, the kid gets louder. And when you then tend to that child, sometimes then they can relax and they can go and do whatever they need to do, and you can get back to what you were trying to do. It's similar with voices for some people. Beyond that, there's any number of strategies, and I would encourage people who are interested more in this to look at some of the websites online. There's hearingvoicesusa.org, for example, that has a number of resources on it, including some of the research and strategies that people have used to try and minimize voices or have them go away. But many, many people really look to learning to live with or change their relationship to voices rather than having them go away.
Thanks, Sera. So the last question was, does someone heal from traumatic experiences if they talk about past experiences of trauma? And if so, does it need to be in a controlled environment? And how do we prevent re-victimizing?
I have thoughts on this, but Kathy, do you want to give it a go first?
Sure. So I think what many of us have learned over time is that some of us heal through talking and some of us heal through other ways of communication, and that it's not only talking that makes us able to tell our story or to share whatever that narrative might be. So it's being present to hear when people are ready to tell, interested in telling, trusting you enough that you might be able to hear what that experience has been. I think in our advocacy, we're hearing it all. We're hearing other people's experiences all the time. So what gives us the capacity to take it in, to listen without judgment, to believe what people are telling us, and to stay present is really what's important. I think that, what I hear around re-victimization is that if you are present and can stay connected and be there, that there's little chance of that. And if you're transparent in terms of how you're navigating yourself when you're hearing things and saying, you know, I thank you for sharing, and letting people know that you heard what they said. Also taking care of yourself and having places where you can be reflective and express how you're feeling about what you're hearing. I mean, I think all of that is important. I think peer support, we've been, again, being present for each other all the time and being able to hear. So I think as advocates, we're very much open to and available for hearing what people's experiences are and figuring out when we've reached a place where we don't have the capacity to hear a whole lot more. And I think that's where good supervision comes in. That's where good practice and good policy comes in about how we support staff and self-care. I think the other piece is that I think we're often worried about re-traumatizing, which is doing more harm. I think we're also often worried about people reenacting or re-experiencing what's happened to them. And it happens, and I think creating spaces where where we can be transparent and we can name those things, so that if I'm talking with you and we're both feeling that and we're feeling the weight of the conversation, we can say, you know, can we walk and talk, and how about a break? Or, you know, being able to actually understand the power of relationship, the power of sharing, but also not demanding that people share, and providing lots of different ways for people to express what's going on with them.
Yeah, and I would just add that, really to echo something I said earlier, the idea that if someone wants to share, that it must be done in a controlled environment, at least for me, would really reinforce this idea that what I have to share is too much or is bad or something that people need to be protected from or that I need to be protected from. And that's not necessarily going to be helpful for a lot of people. There has been this sort of history and mythology of people who have struggled in these ways being really fragile when in fact they're really resilient. And the choice to be able to share or not share with who I want to share or not share with is actually really empowering.
Thanks. You know what? I just noticed the time, and I'm going to have to do the wrap-up. So I'm sorry to cut off this last piece because I think it's really important. But I want to thank you both for such a wonderful webinar today, and to thank Caption Colorado for providing today's captioning, and to thank Angelica for making the webinar run smoothly. And last but not least, to thank all of you for spending your time with us at the National Center on Domestic Violence, Trauma, and Mental Health. Within the next week, we'll send you a follow-up email with a link to the recording of today's webinar, in addition to the slides and handouts that have been referenced, all of which will be available on our website. You'll also receive a certificate of attendance for your time today. At the end of the webinar, you'll be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, we would be most appreciative. Thanks again, and we hope you all have a great afternoon.